thank you. It's a pleasure to be here today. Compared to the last couple of discussions, this might be tending towards the boring side a little bit. So we're going to talk about insurance. Tony asked me, what would be appropriate. I said, well, we have a few changes on the horizon in the Affordable Care Act and Medicare, so let's kind of focus on that. First, for the ACA, we're entering our third year of implementation of Affordable Care Act compliant health care plans. Fortunately, here in Southwest Ohio, unlike other states, we've got a pretty robust competitive market, so that's helping provide consumers lots of choices and keep costs down. The preliminary rate filings that the carriers all send to CMS, the Centers for Medicare and Medicaid Services, were largely under 10%. That's the threshold where CMS will publicly post them on the website, and you can go see who's gouging the consumer. So we really don't know what's coming at us for rate increases or premium increases this fall yet, because with rare exceptions, nobody in Ohio filed a rate increase of 10% or higher. Now, that probably sounds like a lot if it's going to be 8 or 9, but I imagine there are people sitting in the room who work for organizations that sponsor employee health plans that have been faced with repeated double-digit premium increases over the past several years. So that maybe kind of puts it in perspective for us. We have one carrier exiting the ACA market, that's Assured Health. They've decided to pack it in. They're not going to write ACA plans anymore. The second aspect I want to talk about with ACA is we've got a significant change coming in 2016 on the individual mandate or the tax penalty that we're subject to if we don't have health insurance. Now, there's multiple ways to have it. You can be in Medicare, you can be on Medicaid, you can have an employer-provided plan, you can be retired military, and you've got TRICARE. But if you don't have one of those, which is considered creditable, it's as good as ACA, and you don't buy it on your own, you're going to pay a tax penalty when you file your income tax return. Pretty significant increase. In 2015, that penalty is $325 an adult, half that amount for a child under 18, and a family cap is $975. In 2016, it increases, and it's going to go to $695 per adult, again, half that for kids, and a family cap of $2,085, or 2.5% of household income. So let's look at a couple of examples. A single person, $50,000, and they're like, I'm bulletproof, they can't make me buy it. Well, he's right, they can't make him buy it, but they're penalizing. And that guy's going to pay $1,250 when he files his taxes. Family of 4, $70,000, no health coverage. They're looking at $2,085 tacked onto their tax bill because they don't have a qualifying health insurance plan. So something to keep in mind. Last week, CMS announced that they're going to commit another $67 million to navigators. That's people that are hired. They're not trained and licensed as insurance agents, but have got some general knowledge to help people understand what their options are and kind of push them towards enrollment to try to get more people enrolled. In Ohio, we've got a problem. Only 25% of the population that was uninsured when the ACA rolled out have now enrolled themselves. So about 34,000 out of over 900,000. So compared to the national average, which is 40%, we've got a lot of uninsured folks still running around, some of whom probably still don't understand what's going on and what their obligations are. That led, this past year, that led to a special enrollment period that CMS rolled out kind of on the spur of the moment after the original enrollment window ended, because people were figuring out when they went to see their tax guides and taxes, oh, where'd this penalty come from? I didn't know I was going to get penalized. But even with that and the special enrollment window, we've still got hundreds of thousands of people in Ohio that are not yet insured. Open enrollment this fall will be shorter. Opens on November 1, closes January 31, so it's compressed. The first year we went all the way out to March 31. The remainder of the year we're in what's called lock-in, and so people cannot go out and buy insurance even if they want to, unless they're subject to certain life
life change triggers: marriage, divorce, birth of a child, involuntary loss of a health care plan. So they're pretty well stuck for a year, and they're stuck paying that penalty. Last item on ACA, the threshold separating the definition between small employer group plans and large employer group plans is going to increase from 50 employees to 100 on January 1. What that's going to do is move the boundary on plans that are subject to community rating. The ACA imposed community rating on health plans, so the idea was to kind of level the cost basis. But if you're at a plan that's had good medical loss experience, and therefore you've been paying as an employer lower premiums than the general market, and you're in that 50 to 100 zone, guess what? It's going away. So there's a lot of speculation that that's going to drive up plan costs, and in turn there's speculation that some employers will terminate their health plan and send their employees into the open market. Hopefully, if you sponsor a group plan, or your organization does, your benefits broker has already talked to you about that. Let's shift to Medicare. Two significant changes are on the horizon for Medicare beneficiaries this coming year. One, not so big. We continue on this glide path, kind of an evolutionary change with Part D drug coverage, where by 2020 the coverage gap, or what's known as the donut hole, will be eliminated. Now, keep in mind the general proposition of Part D drug coverage is that we as participants pay about 25% of the cost of our drugs. So as we go into 2016, we'll see the standard Medicare Part D plan design deductible will increase slightly. It'll be $360. We'll see a slight increase in both the entry and exit points for the coverage gap. And then we're going to see a little bit of an increase in the out-of-pocket cost to people that do go through the coverage gap and now they're catastrophic coverage. So their cost for generics and brand name drugs will increase slightly. The one benefit to everybody in that plan is if you get in the coverage gap, you'll pay a little less for your generics while you're there. Part D is pretty complex, so if you've got other questions on that, why don't I handle those after the end of the meeting. The other area that will be concern to a lot of people is the Part B Medicare premium. Part B is the portion that covers outpatient services, going to the doctor, the emergency room, getting the MRI at the freestanding facility. According to an August research paper from the Center for Retirement Research at Boston College, they think Part B premiums for new Medicare enrollees and a certain portion of the current population are going to increase significantly next year. About 75% of the cost of Part B is paid for out of general government revenues. The other 25% is financed by the Part B premium that Medicare beneficiaries pay, generally withheld from their Social Security benefit before it goes to the bank. The problem is recent estimates from the Social Security Trust Fund trustees say there won't be any COLA, or cost of living allowance, added to Social Security next year. So that's the third time in the last 40 years that's happened, if that comes to pass. The premium setting mechanism for Part B protects about 70% of the Medicare eligible population. In other words, they can't be given a Part B premium increase if their Social Security didn't also increase. So they're held harmless. So in that case, if Social Security doesn't go up, they don't have a premium increase, they're still going to pay $104.90 per month. The remainder of the beneficiaries aren't going to be so lucky. Under current law, the premiums for the remaining beneficiaries have to be adjusted to whatever level necessary, so it offsets the premiums that weren't collected from the people that are held harmless. So, current estimate from this center at Boston College is that in 2016, new enrollees to Medicare, those turning 65 for the first time, or those who are signing up the first time because they hit their 24 months on Social Security disability, will go up to $159.30 a month. That's a 52% increase from where we are today. Higher income participants will probably pay multiples of that because there's already a thing known as an IRMA in
income-related Medicare adjustment that raises your Part B premium if you're at higher income thresholds. So, watch the paper. This is, interestingly, this has been largely unreported in the press if you don't go out and look for it. It's like nobody wants to talk about it, but it'll be coming home to roost here pretty soon unless something happens dramatically in the final quarter of the year that would drive a increase in the Social Security benefit. So I guess in sum on that, for 70% of Medicare beneficiaries, 2016 looks kind of, stable as we transition along. But for 30%, they're going to get some pretty rude surprises, particularly, well, in either case. If you're a high-income beneficiary, you're going to get a surprise, but you can handle it. The people that are really going to be surprised are the people who have been planning for retirement. I'm turning 65. I know Medicare is going to cost me $105 a month, and now it's $159.
What?
So I'll steal a page from our last presenter to tell a couple of short anecdotal stories. I do the same kind of work, by the way, that Amy Gephardt does. This started out as a second career retirement job. It's turned into part that, but a labor of love because of the impact I bring to the lives of some of my clients. Last week while on vacation, I got a phone call back from a lady that previously had asked for some advice, and she found a new job. She had a job, lost it. Kids went on CHIP, which is Medicaid for kids, because she couldn't afford COBRA. But she's like, I got a job, and I know they're going to kick my kids off the CHIP. And I'm like, well, okay, but let's go see what we can do for you in the marketplace. So long story short, we got her into a special enrollment period window. She's paying about $200 a month for coverage that would cost her $700 a month without the ACA and the premium subsidy. And she's good for the rest of the year. And hopefully next year her job continues to accelerate, and she might end up at the point where she's got to pay that whole premium, but with higher income she can afford to do that. On the Medicare side, I run into situations all the time where people, they're sitting there with Part A and B, and they may have a drug plan and nothing else. And that is a recipe for bankruptcy. So they've either got to figure out how to spend their limited retirement dollars and buy a Medicare supplement, which plugs the gaps in traditional Medicare, or they've got to get into a Medicare Advantage plan, which we're blessed here in the Miami Valley. We've got still a good assortment of zero premium or low premium plans. You pay co-pays when you use services, but we're used to that, right? The neat thing is you get this maximum out-of-pocket limit or a safety net. If you hit that, you don't spend another dollar all year on your medical care. I've run into people that don't understand that, and once they get the picture, then then they're picking the right solution for them. Or the other one that just puts a warm, fuzzy feeling in your stomach is when you walk into a home and you can tell there's probably a limited income scenario. When you talk through that, you find out your client qualifies for extra help with prescription drugs. It's a federal program. If you're below certain income asset levels, they'll pay your drug premium on your drug plan if you've got one, and dramatically reduce your copay. So a $90 a month copay for a brand name drug might cost you $6.60. They don't know about it. They've never heard about it. It's not well communicated. It's a paragraph this long in a 150-page book called Medicare Advantage. And that's the kind of work we do, independent agents, get people signed up. Any questions?